بسم الله الرحمن الرحيم. Let us start this new session with vasculitis. The first speaker, Professor Dr. Rashid Luqmani, University of Oxford, UK. Professor Luqmani will talk about assessment of activity and damage indices of vasculitis. Virtual طبعا من انجلترا.
I'm Rashid Luqmani, and it is a great pleasure for me to present to you about assessment of disease activity and disease damage in patients with systemic vasculitis. I'm very sorry I can't be in Alexandria in person, and I do hope you have a great meeting. The talk I'm going to give you is really focusing on how to best evaluate a really complex set of conditions, primarily focused on the ANCA-associated vascular disease, the anti-neutrophil cytoplasmin antibody-associated vascular disease, typically granulomatosis with polyangiitis or microscopic polyangiitis. And you can see here in these two graphs of the individual involvement of different organ systems in these two diseases, and you can see the pattern across different clinical studies showing the dominance of upper airway, ENT, lung, and kidney disease in GPA, whereas by microscopic polyangiitis, by contrast, the kidney and the skin, to a lesser extent the lung, are involved. But across the board for both sets of diseases, you have multi-organ involvement. And if you look at a comparison with EGPA, eosinophilic granulomatosis with polyangiitis, you will see a similar, very wide distribution of clinical features. So in 1994, some 28 years ago now, I published a way of evaluating patients with disease activity assessment in vasculitis, the Birmingham Vasculitis Activity Score, and we revised that score in 2009, and this is the version that I'm showing you here. It's a single one-page piece of paper which has an item list, a checklist for you to document the disease that you see in your patients, and there are some guidances around how to evaluate BVAS and some arbitrary time frames to allow you to consistently evaluate the patient to determine whether disease appears to be active and worsening or new, or whether indeed the disease is diminishing. It's either persistent or it's no longer active disease anymore, and it may have transformed into damage. And damage assessment is the second sheet I'm showing you here, which is a way of documenting the longer-term consequences of having a diagnosis of vasculitis. Both of these measures, the BVAS and the VDI, have been accepted some 11 years ago as part of the core set of items to be used for evaluation of patients with vasculitis in clinical trials. And there are a growing number of ways to evaluate disease activity, damage, and also patient performance, patient function in patients with vasculitis for clinical trials. But increasingly, this is now reaching clinical practice because where it comes to use of expensive therapies such as rituximab, there is a requirement in a lot of countries to ensure that patients who have active disease are being offered these drugs, and that there is a way of measuring the response to these therapies. Now, BVAS is a predictor for outcome. Here's a study from the French group looking at baseline disease activity levels and then following up patients to see what the survival rates were like. And you can see for those patients with a low score at baseline, the survival curve was much better than those patients who had a very high disease activity at baseline. As you'd expect, multi-organ disease predicts poor outcome. Now, BVAS is used as a means to evaluate the benefit or not from individual drugs. So this is the RetuxVAS study using BVAS as the outcome measure, the main outcome measure, to measure the responsiveness of the disease to either rituximab or cyclophosphamide. BVAS is also used as a definition of what is defined as relapse or as remission. So both in the EGYSIR and Cyclops trials, looking at different regimens of using cyclophosphamide in the early 2000s, BVAS was the main parameter to define these categories of relapse or remission. BVAS has subsequently been validated in a Japanese cohort, predominantly with microscopic polyangiitis, and it does also predict outcome in terms of survival time and mortality rate. And last year, the avacopan study looking at the role of avacopan instead of prednisolone for maintenance therapy in ankylosing again used BVAS as the means to define whether the patient was having a relapse or not. Earlier this year, in the European study looking at mepolizumab, an antibody used to treat EGPA, the main parameter used to determine resolution or improvement in disease was indeed the BVAS, and you can see the BVAS scores being measured over the time frame of follow-up, and in fact mirroring quite nicely the steroid doses being used. And so you can see that patients were being better controlled and therefore needing less treatment. Now, there are predictive values for BVAS beyond just mortality. This study from 2018 took 500 patients from one center in China. Patients mainly had microscopic polyangiitis, and BVAS does emerge as an additional risk factor beyond cardiovascular disease. So having an initial high BVAS is predictive of poor cardiovascular events and also cardiovascular death. Damage, which is the other side of disease evaluation that we're talking about today, is a fairly common feature in ankylosing. And if you look over time, damage accumulates. So here, looking over a period of 5 years, 60 months, in the first 4 European studies of ankylosing, you can see whichever the trial, the damage scores are going up and up. And that's because damage is an irreversible score, unlike BVAS, which goes up and down. Damage only goes either up or it stays the same. And so scarring is accruing in these patients. And if you look at the impact of the scarring, on the right-hand side, you've got the damage index at 6 months as a predictor for poor outcomes. So those patients who had low or no damage in the first 6 months had a much less likelihood of dying over the subsequent time frame. But those patients who had a damage index of at least 5 items of damage by 6 months were at a much higher risk of dying over the next 5 to 10 years. The most common forms of damage seen early on would be renal damage in ankylosing, proteinuria, reduction in glomerular filtration rate, but also obviously with the patients with GPA, especially in the gray, you can see upper airways damage and peripheral neuropathy and high blood pressure. By the end of a long-term follow-up study of patients with ankylosing, again, the impaired renal function and blood pressure emerge as the most important, most common features of damage. But again, some of these other features are starting to emerge, particularly malignancy. Now, taking neuropathy as an example of a damage item, you can see how over time the amount of damage might stabilize after 5 years, having increased initially in this cohort of patients with ankylosing. And if you specifically look at nerve damage, then around 15 or 20% of patients by 5 years will have accumulated neuropathy. And this is unmet or unaccounted for morbidity in this cohort of patients that we are becoming increasingly aware of as a result of our documenting this. And we've recently published an update of these figures with very similar findings. Now, in your own country, there was a nice study last year taking about 100 patients with Behçet syndrome and looking at their damage, and their index mean level was 3.5, but it varied from 1 to 10, and there was a significant association with most parameters associated with Behçet's disease. So BVAS and VDI are slightly complicated assessments. They are slightly different, and for that reason we've created a training site to enable you to use these tools more readily. This is the website address for the training website, and for academic institutions this is free to use, so please do make use of us if you wish. I put disease activity assessment and disease damage assessment right in the heart of how I evaluate patients with vasculitis. I will diagnose their vasculitis, perform that disease assessment right at the beginning, treat them, and then re-evaluate them and treat them more with remission therapy and then maintenance therapy, and keep re-evaluating them. So the key is that at every stage, when you evaluate the patient, do it formally, use a BVAS, use a VDI. That will give you a much more reproducible way of determining their clinical state. And if they have a variation, it appears that they are deteriorating, then investigate what that is due to and consider whether they are flaring and require more therapy. So this will guide your therapy as you apply it to these patients. And using both BVAS and VDI means that you're accounting for the problems that you're seeing in those patients as either disease activity, in which case you have to consider more immunomodulatory therapy, or they are due to damage, in which case you need to support those patients with managing their comorbidity and avoid using too much immunomodulation. Now, things have moved on a little bit. We now have apps for these things, and this is the QR code which your mobile phone camera could be pointed at to get you to our website. And this is on my mobile phone. I recorded this earlier, where I'm going to use my mobile phone to record the disease activity and calculate the BVAS for a patient with vasculitis. First assessment of their disease, they have a bit of muscle pain, myalgia, they've got an ulcer on their skin, some mouth ulcers, no upper airways disease or chest disease. There seems to be some valvular heart disease again, which I think is all due to the vasculitis. No abdominal, but there is some microscopic hematuria, but normal renal function, no neurological features. And I've just calculated the BVAS score as 17, and I can see exactly what that's made up of, and I can copy a summary of that and put it into my medical records if I want to, or in a trial record if I want to. And a similar thing for VDI, so you can also use that QR code to get to the VDI. And you can use the mobile phone to record this, or you can go to the same website and do this on a computer. We also have some training examples for BVAS and VDI. If you, again, point your mobile phone camera to either this QR code or this one, it'll take you to some training examples where I've described the case for you, and you can then go through the case and record the BVAS or the VDI, and they'll give you a mark depending on how well you scored the correct answers or not. But more formally, we have a training system set up which does or can include a training presentation that I or others can give, accompanied by some video tutorials and training manuals, allowing you to go into the system with a password, access, login, and do the practical sessions of a series of BVAS and VDI cases. The cases would be outlined in a little half a page summary here, and then you would go through each case and score them, and then you'd get marked on your progress through the system. Hopefully you'd go down this green path and we can issue certificates of passing or recommend some more cases if not quite there. So you can monitor your own progress as you go through the system, doing each case at a time to see your overall pass mark. And we set a mark of about 85% for BVAS and 75% for VDI. So here's an example of a typical BVAS scenario. Again, as I've shown you already, the BVAS form is here, the description of the case is there, and here I've scored it for you, and you can see that on going back into the system after I submitted the score, it's detected that I've made a few errors, and it will tell you what the errors are in the left-hand corner, so you can see how you're doing in each case, give you some feedback automatically once you complete. The ultimate goal would be to achieve complete success with a high score, and this is a real screenshot from somebody who passed well, and you can see that our average scores are pretty high, 98%, 92% BVAS and VDI, and we have a series of cases that really help you to understand how to use the tools in complex cases. We start with more simple ones, and then we build up to more complex ones. And it is somewhat of a time-consuming exercise. It takes about 4 hours on average to do this for BVAS and VDI together, and each of the 30 cases are done, 30 for BVAS, 30 for VDI. And looking at how long it's taking people to do this, we know that at the beginning it takes a bit longer, 10 minutes or so on average. But as you progress through the cases, and as the cases get more and more complicated, the time is coming down because people are learning how to use BVAS and VDI. We have a similar slide for VDI, this is for BVAS, and they're getting more accurate so that at the end, the last few cases are taking less than 2 minutes to do. So in a very brief time, I've given you an overview of how important I think BVAS and VDI are central to the management pathway for systemic vasculitis in helping to not necessarily guide your therapy itself, but to guide the justification for your therapy, because you have demonstrated both to yourself and to others, particularly to funders if necessary, that your patient has active disease and has then responded to the treatment, or indeed has not responded to the treatment in terms of BVAS, and you can then justify escalating your therapies. So I'm very happy to take questions on assessment of disease activity in vasculitis. Thank you very much for your attention.
Can I have a question? Is this mic working? Thank you very much, Professor Lokhmani, for this wonderful presentation on a very important topic in the field of vasculitis. Actually, in your experience, should we include the damage indices in all drug trials, putting into consideration that damage is irreversible by definition? Nevertheless, it goes into stages.
So, what do you think? Which one of the indices should we include in the drug trials designed for vasculitis? Professor Lokmani, did you hear me?
Dr. Professor Rashid Lokmani is not with us. He's not online.
It's not live? I'll record it because he said you might ask any questions. Okay.
Our next speaker is Professor Mervat Abu Gabal from Ain Shams University. She will give us a presentation on monogenic vasculitis. So proceed, Professor Abu Gabal. We're listening.
صباح الخير. First of all, I want to thank my great professors. I want to thank our scientific committee and organizing committee for allowing me to participate in this great event. My topic today is monogenic vasculitis. Actually, I have few highlights regarding the differentiation between monogenic versus complex disorders in general, a few highlights regarding the meaning of precision medicine. Also, we will revise rapidly classification of necrotizing vasculitis. We will revise few forms of monogenic vasculitis. Finally, the message of my talk today will be summarized. At first, let's understand the difference between monogenic disorder and complex disorder in general. Monogenic disorder requires single gene variant to produce its phenotype, to produce its clinical manifestation. Usually, monogenic disorder has a strict Mendelian inheritance pattern, like sickle cell disease, cystic fibrosis, Duchenne muscle dystrophy. On the other hand, complex disorder requires multiple gene variants to produce its phenotype after interacting with environmental factors, like in cardiovascular disease, asthma, diabetes, and cancer susceptibility. So what? The answer to this question will be postponed till I talk about monogenic vasculitis. Now, what about history and evolution of vasculitis classification system? Rapidly, the first form of vasculitis discovered in 1860 and was termed as periarteritis nodosa. In 1952, Pierre-Lézec introduced the first structural classification of vasculitis based on vessel size. It included 5 entities of vasculitis. These entities were giant cell arteritis, polyarteritis nodosa, Serge-Strauss syndrome, Henoch-Schönlein-Purpura, and hypersensitivity vasculitis. In 1990, EGYSIR released the classification criteria for 7 entities of vasculitis. These 7 entities included the previous Pierre-Lézec 5 entities, plus Takayasu arteritis and Wegener granulomatosis. In 1994, Chapel-Hill introduced definition and classification of vasculitis, which was revised in 2012. This Chapel-Hill classification included 10 entities of vasculitis, which were the ECR, the previous ECR classification of vasculitis, minus hypersensitivity vasculitis, but plus Kawasaki disease, microscopic polyangiitis, essential cryoglobulonemic vasculitis, cutaneous leukocytoclastic vasculitis. In the same Chapel-Hill classification, they introduced pathologic description for some forms of vasculitis when possible. Also, they incorporated serologic marker like ANCA into this classification. Since that time, 2012, no further classification of vasculitis till in 2017. In this review article, authors introduced classification for necrotizing vasculitis, but not released by ECR or EULAR. They stated that necrotizing vasculitis include classic polyarthritis nodosa, the classic complex disease, also include the 3 ANCA-associated vasculitis, again include hepatitis B virus-associated vasculitis, and here this form of vasculitis is considered as secondary vasculitis to underlying probable etiology. And it was immune complex disease, or it's immune complex disease. Since that time, no further subdivision of polyarthritis nodosa for being with or without hepatitis B virus infection. There is classic primary polyarthritis nodosa and hepatitis B virus associated necrotizing vasculitis that resemble polyarthritis nodosa but is immune complex disease and is secondary vasculitis. In the same literature, they mentioned monogenic variant of vasculitis or monogenic disease to include SAVI-DADA2, familial Metrian fever associated polyarthritis nodosa-like picture, and primary immune deficiency associated necrotizing vasculitis. Also, in the same literature, they mentioned the definition of monogenic vasculitis. They stated that severe mutations in single gene can result in similar phenotype to that seen in multifactorial complex disease. And here in the same literature, they give 2 examples. The first example is for polyarthritis nodosa as primary complex form of vasculitis with its monogenic variant, which mentioned before, SAVI-DADA2, familial Metrian fever associated necrotizing vasculitis, and primary immune deficiency associated necrotizing vasculitis. They give another example regarding Behçet disease. Behçet disease is well known as a primary complex form of vasculitis, and there is monovariant or monogenic variant of Behçet disease that's haploinsufficiency A20. Single gene mutation in gene encoding for A20 protein result in Behçet-like disorder, which is monogenic variant. This means that, for example, as I said, in Behçet disease, this complex Behçet disease, which is associated with multiple gene variants, whether in HLA region, like HLA-P51, HLA-P57, HLA-A03, or outside HLA region, like interleukin-23 receptor, interleukin-12 receptor P2 locus, interleukin-10 locus, and so on. On the other hand, there is monogenic variant of Behçet disease, which results from single gene mutation, gene encoding for A20 protein, which result in loss of function and deficiency of this protein, which augment signaling in nuclear factor kappa P pathway with increased production of pro-inflammatory cytokines dependent on this pathway. So what? There is primary complex vasculitic disorder and monogenic variant of this disorder. As you see, in monogenic variant of vasculitis here, there is specific or definite biologic pathway with its known or definite pro-inflammatory cytokines dependent on it. This biologic pathway with its dependent pro-inflammatory cytokines could be considered as new therapeutic target. And this monogenic variant of Behçet disease or of polyarthritis nodosa, as the previous example, may not respond to the standard therapy recommended for the primary complex disease, but require more targeted therapy. Hence the need for what's called precision medicine. From where the idea of precision medicine? It came from certain observation that a percentage of vasculitis patients don't adequately respond to standard treatment, hence the need for precision medicine. Precision medicine is defined as designating medical care for each person with optimum efficiency in prevention and treatment by considering individual variability as regard genes, genetic profiling, environment, and lifestyle. This means that precision medicine enables translate bench-side knowledge to bedside and provide targeted treatment for the patient. Since that time, numerous genetic studies have been carried out to identify, number one, susceptibility loci and corresponding biologic pathway in vasculitis pathogenesis, which could be considered as new therapeutic target. Also, they try to identify genetic predictors of treatment response to improve use of existing drugs. Again, genetic profiling of patients provided by genetic studies carried out by different study groups like EGYSIR and Immunoship provided important step forward in our understanding of vasculitis pathogenesis. And there are several EGYSIR results in different forms of vasculitis, like in Henoch-Schönlein-Purpura, Kawasaki disease, ANCA-associated vasculitis, Takayasu arthritis, and Behçet disease. Even more, in this literature, they provided timeline for the genetic findings for precision medicine in vasculitis, starting from 1975 by discovery of the genetic association between Behçet disease and HLA-P51 till 2017 with the discovery of the genetic association of giant cell arthritis. Even more, in the same literature, they provided table for different forms of vasculitis with their associated susceptibility loci outside HLA region and their corresponding chromosomal region. Even more, they provided another table for some forms of vasculitis with their gene-associated treatment response. Here is a time to tell certain fact, which is very important and well known especially by drug companies. The fact is that any drug with genetic support will have twice the opportunity to pass rapidly from phase 1 to approval compared to another drug without genetic support. Now, returning back to monogenic vasculitis. During all these genetic studies serving precision medicine, they discovered monogenic variant of vasculitis. Now, let's revise a few of them. The first one is DADA2 disease, deficiency of adenosine deaminase 2. Adenosine deaminase 2 is produced mainly by monocyte and macrophage of bone marrow and is essential for leukocyte growth and endothelial stability. When there is mutation in gene encoding for adenosine deaminase 2, this results in deficiency of adenosine deaminase 2, which in turn results in phenotype of necrotizing vasculitis that's similar to polyarthritis nodosa regarding its clinical manifestation and its histologic manifestation. But there are two points which are different from polyarthritis nodosa, the primary complex disease. These 2 points are, number one, DADA2 disease is autosomal recessive, so usually there is positive family history in patients with monogenic variant with DADA2 disease. Also, DADA2 disease affects cerebral blood vessels. Consequently, usually there is early stroke in patients with DADA2 disease. These 2 points considered as 2 red flags against presence of polyarthritis nodosa in patients with necrotizing vasculitis resemble polyarthritis nodosa. The recommended treatment for DADA2 disease, anti-tumor necrosis factor drugs, and in resistant cases, hematopoietic stem cell transplantation. Even more, in 2021, according to EGYSIR guideline for management of polyarthritis nodosa, they stated that if in patients with clinical manifestations of DADA2 disease, they strongly recommend treatment with anti-TNF over glucocorticoids alone. The second form of monogenic vasculitis is necrotizing vasculitis associating familial Mediterranean fever. Discovery of this form or monogenic variant of vasculitis started by an observation. They observed that there is higher prevalence of polyarthritis nodosa in South Europe and Eastern Mediterranean area, whereas there is high rate of familial Mediterranean fever carrier. With genetic studies, they proved that mutation in familial Mediterranean fever gene MEFV, which encode for pyrene, result in uncontrolled production of interleukin-1, which in its turn result, in addition to serositis and periodic fever, it results in necrotizing vasculitis, resemble polyarthritis nodosa. But with perirenal hemorrhage, higher prevalence of perirenal hemorrhage, and very high acute phase reactant. The recommended treatment for this form of monogenic vasculitis, glucocorticoids, and if there is familial Mediterranean fever, colchicine should be continued, and in resistant cases, interleukin-1 inhibitor. By the way, polyarthritis nodosa is not the only vasculitis in general that associate familial Mediterranean fever. In 1 to 7% of cases, there is Henoch-Lyme purpura. In other cases, leukocytoclastic vasculitis was reported. There are other case reports with familial Mediterranean fever, like coronary vasculitis, large vessel vasculitis, similar to Takayasu, cutaneous vasculitis with immune complex glomerulonephritis. The third form of monogenic variant of vasculitis was mentioned before. This is haploinsufficiency A20, single gene mutation in gene encoding for A20 protein, resulting in loss of function and augmentation of signaling through nuclear factor kappa P pathway with increased production of its dependent pro-inflammatory cytokines, resulting in Behçet-like disorder, similar to the primary complex Behçet disease. In review of 16 patients with haploinsufficiency A20, one of patients had central nervous system vasculitis, another one had retinal vasculitis, a third one had central nervous system vasculitis plus pulmonary artery emboli. In the next form of monogenic vasculitis, usually this occurs in children, SAVI, sting-associated vasculopathy of infancy. What's meant by sting? Stimulator of interferon gene protein. Here there is gain of function mutation of gene encoding for interferon. In gene encoding for sting, stimulator of interferon gene protein. This results in overproduction of interferon 1, which combine or bind its receptors, resulting in increased signaling through Janus activating kinase. This results in necrotizing vasculitis resemble polyarthritis nodosa, and in other patients it can result in picture of granulomatosis with polyangiitis with severe cutaneous vasculopathy, severe interstitial lung disease, and microthrombotic angiopathy. The recommended treatment for this patient is paristinib, which is Janus kinase inhibitor, because the mediating factor or the activating factor is Janus kinase activation. The last form today of monogenic variant of vasculitis are the primary immune deficiency associated necrotizing vasculitis that resemble polyarthritis nodosa. Again, single gene mutation in gene encoding for proteins which are involved in recombination in T and P cell can result in necrotizing vasculitis like resemble polyarthritis nodosa, and the recommended treatment for this form of vasculitis, in addition to glucocorticoids with or without steroid-sparing drugs, due to presence of immune deficiency, the underlying cause should be treated by either intravenous immunoglobulin or hematopoietic stem cell transplantation. Now we came to the message of this talk today, that genetic profiling of vasculitis patient help better understanding of vasculitis pathogenesis, help tailor treatment individually, which serves the goal of precision medicine. One of you will tell vasculitis group as a rheumatologic disease or a rare group of disease. What about monogenic variant? They will be more rare. Yes, more rare. I will tell what about systemic lupus erythematosus, which is more common rheumatologic disorder. Since 2014, the concept of monogenic systemic lupus erythematosus became present, with many forms of monogenic variant of systemic lupus erythematosus which require more targeted therapy were discovered. The most important question now, when to suspect presence of monogenic variant of disease, especially in vasculitis, this must occur when there is a typical presentation regarding age or gender, when there is a strong family history, strict Mendelian inheritance or consanguinity in this family, when there is a typical manifestation like a picture of polyarteritis nodosa and necrotizing vasculitis, but with early stroke and positive family history, or with associating glomerulonephritis, which is not characteristic of polyarteritis nodosa. Lastly, if the disorder is refractory to standard therapy, we must think of a monogenic variant of the disease which require more targeted therapy. Thank you.
Thanks, Professor Dr. Mervat, for this elegant presentation about genetics of vasculitis and the precise or personalized medicine. نستأذنك دقيقتين بس عشان دكتور راشد لقماني اونلاين معانا من لندن.
Just a question, just please.
أنا عايز أسأل سؤال.
دكتور
أولاً أنا عايز أشكرك الأول على هذه المحاضرة القيمة العميقة. أنا سعيد بيك يعني بصراحة، يعني دخلت في قصة ربنا اللي يعلم بها، بس أنا عايز أقول لك الإيجيسير نفسه عمل جواز ستاديز يعني بإشراف البروفيسور جعفر، وعملها مالتي سنتر هنا في مصر، وكانت على جواز في الروماتويد ارثرايتس، وبعد كده كملنا في السيستميك لوبس، كان مع ألمانيا الموضوع ده، واتنشر في الهيومن جينيتكس كما اعتقد يعني. فالجواز ستاديز يعني الحمد لله كانت اول مالتي سنتر ستاديز اتعملت في الاي جي سير. انما يعني مجرد الدكتور رشيد الاول. طب يا دكتوره هنسال الدكتور رشيد الاول عشان هو اونلاين، وبعدين نرجع للكلام معاه.
Professor Lokmani, can you hear me now? Okay. Thank you very much first for this wonderful presentation on a very important aspect in vasculitis, which is damage, of course. In your experience, should we include the damage indices in all of the drug clinical trials designed for vasculitis? Because you know that damage is irreversible by definition. So this point is a bit intriguing for me. I mean, are we looking for something that is not going to change with medication? And, you know, when is the best time to use the indices? And my second question is, what are the medications that really resulted in improvement in damage?
So to answer your second question first, which is perhaps easier to do, I might reverse the question and say, what is the medication most associated with damage? And the answer is always going to be steroid, prednisolone, methylprednisolone. So that is the enemy, if you like, for these patients that we have come to love, and now we come to hate because it does so much harm. And yet we now are in an era where we can afford to tightly control disease with a reducing amount of steroid. And you know from the Pexivas study that you can probably use 50% less corticosteroid to still get the same outcome. And that's a nice randomized controlled trial, the biggest trial there's been of patients with vasculitis in a controlled trial. So I think you've got good evidence that you don't need as much steroid as we used to use. There are also, as you know, increasing uses of medication that can avoid steroids altogether in the long term. But I think the key thing is initial good control. And damage at the beginning, I suspect, is inflicted by the disease and then subsequently primarily by the complications of its medication. And that would be the infections induced by steroids, the steroid toxicity itself, to some extent damage longer term from huge amounts of cyclophosphamide use used to be a historical problem, but we no longer do that. So we have vastly, significantly reduced the amount of cyclophosphamide exposure, but we haven't paid enough attention yet to how much steroid exposure these patients get. And then coming back to your first point, which is about how useful or not the damage index is compared to the activity index, I think, again, to go back in time to 20 or 30 years ago when we first started doing the European vasculitis trials, we needed a way of standardizing patients for entry into the studies, and the standard was they had sufficient disease activity as measured using something like the BVAS, the Birmingham Vasculitis Activity Score, and that the achievement and the aim of those trials was to try and get patients into remission, again, as measured by the Birmingham Vasculitis Activity Score or equivalent. And then thereafter, the longer-term observation of those patients couldn't really use disease activity to observe how well or not the patients were doing, because most of those patients had a little bit of low-grade grumbling disease, and maybe at point of relapse, their disease activity would go up, the BVAS would go up. But what was happening underneath all of that is that they were indeed accumulating a disease burden. And the reason that we've defined the damage index as being irreversible is that cumulative burden of disease in those patients that they experience from disease plus the effects of their drugs and the comorbidities and the complications. All of those have a significant impact, not just on the functioning of individual organs like controlling blood pressure, kidney function, nasal disease, but in fact, damage contributes to risk of mortality. So accumulating a high level of damage within the first 6 months of disease is strongly associated with a very poor outcome. And so damage is actually quite a good prognostic marker, and maybe a more powerful prognostic marker over a longer period of time. Now, it's possible that parts of damage, the damage index, could be defined as being primarily drug-related damage. And so if drug companies are interested in looking at vasculitis in a bigger way, then using parts of the damage index or something like it would be an important measurement of how effective their drug is in keeping patients in a good state of health. I think many drugs now are very good at causing that initial induction and control of disease. What isn't so good is keeping those patients under control with minimal cost to the patient in terms of morbidity. And it's that cost in terms of longer-term morbidity that the damage index is attempting to measure.
Thank you very much.
Yes, Professor Lokhmani. One question more in short about the role of avacopan in management of ANCA vasculitis. You know that in the advocate trial, in the test arm, it used without steroids, as you know. But in the approval of FDA, they advised to add on therapy, including steroids. So what is the exact role of avacopan? It will replace completely steroids or not? Thanks.
I think this is an important area, and it kind of demonstrates that we have far too long relied on steroids to keep the patient comfortable, but actually it probably keeps the doctor comfortable, and I'm sure it contributes morbidity to the patient. Avacopan does offer that opportunity to replace the steroids, apart from that very initial time when you have to induce the patient into some remission, and you need a little bit of steroid during that time. There is a good trial, a phase 3 trial looking at avacopan. It's only one phase 3 trial, but it's reasonably good evidence that you can do just as good a job with avacopan as you would have done with steroids, but without the downside of the steroids. So I think in the longer term, drugs such as avacopan aimed at inhibiting the complement 5A receptor, as you know, may pose a very effective means to control disease. There's a little bit of evidence that in renal vasculitis, ANCA renal vasculitis, avacopan may additionally preserve some kidney function. So that may be attractive as a further long-term benefit of avacopan, as well as removing the steroid toxicity and keeping the patients from flaring. You've actually got the potential benefit. Of course, all of this comes at a cost, and avacopan is hugely expensive compared to steroids. And so your health care policy will dictate whether or not you can use avacopan in these patients. And I think the important aim of the data that we need to produce is to provide the evidence that a drug such as avacopan can offset the healthcare costs in terms of the morbidity you're causing to patients by not giving them avacopan and therefore having to use steroids instead to do that work.
Thank you, Professor Loqmani. We are honored by your contribution. Thank you very much. We hope next year to have you in person with us.
Thank you so much, and I'm very sorry I couldn't be there today.
Okay. If I may be allowed to make 2 comments. Number 1, Dr. علي
أكمل بس
أنا أرد على السؤال بس. هو البيبر الثانية اللي على lupus is submitted and it's in the review process. It hasn't been accepted yet. أنا بس عايز أعمل announcement يعني تعليقاً على كلام الدكتورة ميرفت أو استرشادا بكلامها. We are interested in Aicardi-Gouttière disease. It's a monogenic SLE-like disease with a child onset. If you have patients with a child onset SLE-like cases, please contact me. We are interested in studying its genetic polymorphism in Egypt. Thank you very much.
Thank you.
I think we have to proceed to the next talk because it's
أكمل يا دكتور بس
we are running late.
أكمل بس كلمتين. معلش الدكتور جعفر.
دكتور علي, we have to respect the sequence of speakers.
شكرا دكتور.
Next speaker, Professor Dr. Dina Shaheen, Mansour University. دكتورة دينا will present lymphocytic CNS vasculitis. تفضلي دكتورة دينا.
بسم الله الرحمن الرحيم. يعني مساء الخير على حضراتكم. هي السيشن تقيلة نستحمل بعض شوية. الفاسكولايتس هيفي توبيك وأرجو إن أنا أكون الموضوع بتاعي يبقى خفيف شوية. سعيدة طبعاً بانتمائي للإيجيسير ولوجودي معاكم النهاردة وسعيدة بالحضور. ونبدأ بالليمفوسيتك CNS فاسكولايتس. والحقيقة لما الدكتورة داليا بلغتني من الموضوع يعني أنا حسيت هي قد إيه بتحبني وادتني هدية، وأنا كنت بحسب إن الموضوع صغير. مش هنتكلم كتير على البرنسبل بتاعت الفاسكولايتس. حضراتكم عارفين ان هي انفلاميشن في البلاد فيسل، واي بلاد فيسل may be affected من الارتيريال فينس سايت باي سايز، والكلينيكال مانيفستيشن بتبقى على حسب السايز والسايت اللي affected فيه this vasculature. أي vasculitis may be classified into primary vasculitis, secondary vasculitis, and there is vasculitis mimics، وده نفس اللي بينطبق بالضبط في حالات ال CNS vasculitis. السكندري vasculitis may be أي pathological condition، فإحنا هنهتم النهارده بإن إحنا نركز شوية ونعمل فوكس على الحالات البرايمري CNS angiitis. primary CNS angiitis عندنا شقين، الأدلت وعندنا الchildhood. الفاسكولايتس هي انفلاميشن في السي ان اس بلاد فيسل، وبيحصل معاها انفلاميشن، اوكلوجن، ديستراكشن، وانفاركشن. لما بنقابل حاله سي ان اس فاسكولايتس بيبقى ده الوضع بتاعنا بالظبط. ده الطريق، مش عارفين نمشي ازاي. لكن لما بتكون الحاله سكندري فاسكولايتس تبقى مور اور ليس اسهل شويه في التشخيص. عندي كلينيكال مانيفستيشن بتساعد، عندي سيرولوجي، عندي ماركرز بتقدر تدلنا او بتبقى جايد لينا. لكن في حالات البرايمري سي ان اس انجيايتس بتبقى شويه صعبه وفور دايجنوزس بسبب ان الانسيدنس ريت بتاعه قليل، ما بنشوفهاش كتير، 2.4 في المليون. اللو سنسيتيفيتي بتاعت الانجيو توصل 30%. مفيش كلينيكال بيكتشر خاصه بيها، مفيش لاب تيست هعمله هيشخصها لي. بنفس الوقت الشورست دايجنوزس هو بالباثولوجي، وده في حالات كتيره جدا بيبقى هازاردس واحيانا بيبقى امبوسيبل. فنتكلم على البرايمري انجيتس مره ثانيه. في الادلت يعني البيك انسيدنس بتاعها بيبقى في ال 40-50 سنه، ليها ميل بريفرنس، وزي ما قلنا ان الانسيدنس 2.4. الكريتيريا اللي اتحطت فور دايجنوزس بالتمور سنه 88 بتعتمد على 3 حاجات: انه العيان يبقى عنده unexplained neurological او psychological manifestation، ما عندوش other systemic disease يفسر لي الكلينيكال مانيفستيشن دي، وفي نفس الوقت العيان عنده سبورتيف ايفيدنس من الراديولوجي او من الهيستوباثولوجي. لو ال3 حاجات دول اتطبقوا على ادلت فبتبقى برايمري سي ان اس انجيايتس. لو في تشايلد او اقل من 18 سنه اكسكلودينج نيونيت يبقى دي تشايلد هود برايمري سي ان اس انجيايتس. في 2020 حطوا بروبوزال لاذر كلاسيفيكيشن كرايتيريا، وقالوا نسمي العيان نكلاسيفاي ان هو ديفينيت او بوسيبل على حسب لو عنده هيستوباثولوجيكال ايفيدنس يبقى ده ديفينيت، لكن لو عنده راديولوجي او عنده سي اس اف او لاب ايفيدنس بنسميه ان العيان ده بوسيبل. بس الحقيقه ان هي لسه محتاجه مور فاليديشن. دول الديزيز تايبس او ال5 تايبس اللي معروفين في حالات البرايمري سي ان اس انجيتس اوف ادلت. عندنا الجرانيولوميتاس والليمفوسيتك والانجيوغرافيكالي ديفايند، ودي بتبقى بايوبسي فيها نيجاتيف، وفي ماس ليجن افكت وفي اميلويد بي. الجرانيولوميتاس والليمفوسيتك الاثنين بيتشابهوا جدا في الكلينيكال مانيفستيشن والام ار اي فايندنج، لكن بيختلفوا فقط في حالات الهيستوباثولوجي. في الليمفوسيتك برايمري انجيتس بيبقى في ليمفو هيستوسيتك انفلتريشن بيريفاسكولار اند انترافاسكولار. في الكلينيكال برزنتيشن العيانين دولت ممكن يجوا باي مانيفستيشن، ممكن يجي باكيوت، ممكن يجي بسب اكيوت، ممكن يبقى انسيدوس. احيانا بياخدوا 6 شهور، خصوصا لو واخده السمول فيسل فاسكولايتس ممكن ياخد 6 شهور في لغايه ما يتشخص. الموست كلينيكال مانيفستيشن فريكوينت ان العيان بيبقى عنده هيدك بيرزيستنت، بيزيد في اوقات وبيقل في اوقات، بيبقى ريزيستنت للثيرابي، unexplained. عندهم cognitive dysfunction، الميموري، البروبلم سولفينج، بيجي لهم ستروك، ممكن تبقى فوكال سنسوري او موتور، ممكن يجي سيجرز، ممكن كرينيال بولسز. لكن لو معاها فيفر اورجان افكشن ده بيخلينا نمشي في سكه ان العيان سيستميك او سكندري فاسكولايتس. دي ليست كبيره قوي بالحاجات اللي هي ممكن تعمل يعني تيجي بيها ككلينيكال مانيفستيشن، من اول الهيدك والكوجنيشن والهيميباريسيس والفيجوال ديفكت والفيجوال سيمبتومز والاتاكسيا، حاجات كتيره جدا. نيجي بقى للتشايلد هود برايمري انجيتس اوف سي ان اس. احنا عندنا في البرايمري انجيتس بتاع الادلت انا عندي سبب ممكن يخليني ما افكرش ان المشكله برايمري انجيتس. الاثيروسكليروزس والريسك فاكتور فور ثرومبوزس بيبقى موجود في الادلت بنسبه اكبر من الاطفال، لكن في التشايلد هود لما الاقي جاي لي تشايلد باسكيميك ارتيريال اسكيميك ستروك، في الحاله دي المجموعه بتاعه البرايمري تشايلد هود انجيتس والجينيتك طبعا بتاخد مساحه كبيره جدا من اللاب والافورت في ان انا اثبتها او انفيها. الحقيقه ان احنا ما عندناش انسيدنس ريت، والعيانين دولت اوقات بيبقى معاهم سيستميك مانيفستيشن، لان بعض الفاسكولايتس دي بتبقى تريجرد باي فيرال انفكشن، وكل الحالات بتاعت البرايمري تشايلد هود انجيايتس بتبقى ليمفوسيتك نون جرانيولوميتاس فاسكولايتس. بيبقى معاهم نيورولوجيكال مانيفستيشن هنتكلم عليها حسب بقى نوع البلاد فيسل او السايز اوف ذا افكتد بلاد فيسل. عندي المجموعه اللي هي السمول فيسل فاسكولايتس، دي مجموعه لوحدها، والمجموعه دي بتبقى انجيوجرافي نيجاتيف، يعني اعمل لهم انجيوجرام ما الاقيش فيها حاجه، الاقيه نورمال، لكن بروفد بالبايوبسي. المجموعه الثانيه حسب بقى اللي هي بتاخد الميديوم واللارج فيسل سي ان اس فيسلز، دول بينقسموا لجزئين، جزء هادي وشويه معقول اللي هو المونوفيزيك نون بروجريسيف انجيوجرافي بوزيتيف، والنوع الثاني اللي هو البروجريسيف انجيوجرافي بوزيتيف. يبقى دي الثلاث انواع اللي موجودين. الانجيوجرافي بوزيتيف نون بروجريسيف، وده اقلهم شويه وبيبقى مونوفيزيك وبياخد 1 فاسكولار تيريتوري وما بيتعدهوش، يعني الحته بس اللي سبلايد بالارتري ده هي اللي بيبقى فيها الباثولوجي، وبتبقى يونيلاترال. دي حاجه مهمه ومميزه ليها ان هو يونيلاترال، ما عندهمش اي سيستميك ماركر اوف انفلاميشن خالص، لكن البيشنتس دولت عندهم ريزد فون فيلبراند، لانه طبعا اندوثيليال انجري بيرفع الفون فيلبراند فاكتور عند في العيانين دولت اب تو 2/3. احيانا بيبقى في ارتري تو ارتري امبوليزم، والام ار اي فايندنج بتبقى كاركترستيك وبنشوفها بتبقى يونيلاترال اسكيميك ليجن في الديستريبيوشن بتاع بيج ارتري. غالبا بتاخد السيركل اوف ويلز والميدل والانتيريو سيريبرال ارتري. البروجريسيف فاسكولايتس دي بتبقى مور سيفير شويه، اكستنسيف، ممكن تاخد بروكسيمال وديستال بارت من الارتري، اسكيميك انفلاماتوري ليجنز، وبيبقى معاها هيدك، ده يونيفرسال في العيانين دولت. ممكن يبقى عندهم ديفيوز، ممكن يبقى عندهم فوكال، ممكن تبقى بايلاترال ليجنز، وبتبقى الانفلاماتوري ماركرز ممكن نلاقيها عاليه، والام ار اي برضه بيبقى كاركترستيك، تبقى واخد اكتر من 1 فيسل. الانجيوجرافي نيجاتيف برين بايوبسي بوزيتيف سمول فيسل فاسكولايتس، دي اوحشهم كلينيكالي، والبروجريشن بتاعها وحش، والبروجنوزس بتاعها وحش لو ما اتشخصتش بدري. العيانين غالبا بيجوا بديفيوز انكفالوباثي وكونفيوجن، ديفيوز فوكال ديفيسيت، ممكن يجوا بستيتس ابيليبتيكس، رابيد بروجريشن. البرين بايوبسي ريكوايرد فور دايجنوزس، واتس بيتر ان انا اخش بيه ايرلي لو كان عندي هايلي سسبشن. 90% من العيانين دولت عندهم سي اس اف ابنورماليتي، والام ار اي والام ار اي ما هم الام ار اي ما بيديناش حاجه، لكن الام ار اي بيديني يعني سب كورتيكال وليبتومينانجيال ابنورماليتيز. نبص كده كلوزلي على ايه الحاجات اللي بتميز كل واحد فيهم. البروجريسيف انجيوجرافي بوزيتيف دي بتاخد اللارج فيسل من الانترنال كاروتيد السيركل اوف ويلز، بتاخد الانتيريور والميدل، واحيانا بتاخد البوستيريور سيريبرال ارتري، ممكن تيجي يونيلاترال، ممكن تبقى بايلاترال، بتبقى ديفيوز ليجنز. 50% من العيانين دولت عندهم سي اس اف ابنورماليتي، ما بنحتاجش بايوبسي لان الام ار اي بيبقى دايجنوستيك. النون بروجريسيف برضه بتاخد اللارج فيسلز وبتبقى يونيلاترال، وبنؤكد ان هي بتاخد يونيلاترال 1 فيسل بس، وما عندهمش اي سيستميك ابنورماليتي في الانفلاماتوري ماركر ولا في السي اس اف. السمول فيسل فاسكولايتس دي بتاخد السمول فيسلز، بتاخد الليبتومينينجيلز، وبيبقى معاها مننجيال فيسلز، وبيبقى معاها ليبتومينينجيال انهانسمنت، ديفيوز ليجنز. السي اس اف ابنورماليتي موجوده في اكتر من 90% من العيانين دولت، والبايوبسي هي اللي بتدينا فاينل كونفيرميشن. طيب ايه بقى الديفرنشال دايجنوزس؟ الحقيقه انا عندي ديفرنشال دايجنوز كبير جدا، بس امتى اشك ان العيان ده عنده سكندري سي ان اس فاسكولايتس؟ لو عنده مالتي سيستم افكشن، لو عنده انترنال اورجان، كدني، لانج، سكين، بون مارو، عنده الانفلاماتوري ماركر الهاي اس ار، البليتلتس، السيفير بيرزيستنت انيميا، الكونستيتيوشنال مانيفستيشنز، الفاريسيلا زوستر واحده من الحاجات اللي بتديني كاتيجوري كده اسمه فاريسيلا زوستر ارتريوباثي، وده بيبقى موجود في الاطفال ويقابله عندنا او حاجه يعني ده كومن في الاطفال، وعندنا احنا في الكبار الريفرسبل سيريبرال فازو كونستريكشن سيندروم. الحقيقه الوقت لا يتسع ان احنا نتكلم عن الحاجات دي، بس قلت ننوه عليها. الديفرنشال دايجنوز يخش فيه حاجات كتيره جدا، من اول الاميون ديزيزز، الانفكشن، الجينيتك، الثرومبوتيك، الاسروسكليروزس، حاجات كتيره جدا. وظهر عندنا في السنتين الاخرانيين ضافوا للانفكشن الكوفيد. نشخصها ازاي؟ الحقيقه انا عندي كلينيكال سيمبتومز سجستيف ان العيان ده فاسكولايتس. عملنا له MRI، عندي سكيميك ليجنز واضحه. والMRI ده الحقيقه فيه حاجات كتيره جدا، يعني حسب احنا شاكين في ايه الموداليتي بتاع الMRI هو ده اللي بنستخدمه. احيانا بنعمل CSF لو افيلابل والعيان وبيقول لي فيه ايه. عملنا اكسكلوجن لكل السيستميك ديزيزز. عندي لارج فيسل افكتد واضحه في الMRI الباترن بتاعها والMRA والCT انجيو كويس، ما كانش فيه يبقى على طول بروسيد فور بايوبسي. دي نفس القصه بالنسبه للتشايلد هود. يبقى العيانين دولت محتاجين ان انا اعمل لهم بيز لاين انفلاماتوري ماركرز وكريات والسيرولوجي كله بما يفيه الاميونوجلوبولين ليفل والالكتروبروتين الكتروفوريسز والكومبلمنت واللمبر بانكشر. الحقيقه اهميته انه مش بس ان في ابنورماليتي في حالات، يعني ابتو ان هو اكتر من 90% من البيشنتس بتاعت الادلت هود CNS فاسكولايتس وفي السمول فيسل فاسكولايتس بيبقى في ابنورماليتي، في ليمفوسيتك بلايوسايتوزس بيبقى في ريزد بروتين، لكن كمان اكسكلود المالجنسي والانفكشن. يعني هو ده الاهم في اللمبر بانكشر، ان انا اكسكلود المالجنسي والانفكشن. سيتولوجي، فلو سيتومتري، كالتشرز، فيرال PCR، والEEG ما بيديش نتائج كبيره قوي في التشخيص. الراديولوجي الMRI بقى بكل بالفلير والديفيوجن ويتد والتايم اوف لايت والبوست جادولينيوم، حاجات كتيره جدا. هم بتوع الراديولوجي بقى اعلم مننا في ذلك، بس بيدينا حوالي 93% ابنورمال فايندنج في العيانين دول. الCT انجيو والMRA والسيريبرال انجيوجرافي. اخر حاجه هو البرين بايوبسي، مور اور ليس انفيزيف شويه، 25% فولس نيجاتيف ريزلت لو انا داخله بالابره مش في الباثولوجي، يعني او ما دخلتش ديب قوي وجبت جوه، فبالتالي هيديني فولس نيجاتيف ريزلت، لكن لغايه دلوقتي هو الجولد ستاندرد فور دايجنوز. يبقى دي الرود ماب بتاعتنا في التشخيص بتاع حالات الكلينيكال ايفالويشن. سيستميك انفلاماتوري ماركر لو موجوده اوكي، سيستميك ديزيز ورك اب هدور عليها، الMRI سجستيف والCSF اناليسيز ما كانش، يبقى وي هاف تو بروسيد فور برين بايوبسي. التريتمنت بتاع البرايمري انجايتس اوف CNS في الادلت والتشايلد هود هو ذا سيم تقريبا، وبيعتمد على الستيرويد والسايكلوفوسفامايد. مفيش كلينيكال ترايل ولا ايفيدنس بيزد، كلها اجتهادات، لكن اتوجد انه من الحالات اللي اخذت استيرويد خصوصا بالس استيرويد مع سايكلوفوسفامايد اب تو 3 شهور، وبعد كده باندكشن، وبعد كده مينتننس بليس توكسيك دراج. احيانا بنستخدم ريتوكسيماب في الريزيستنت كيسز، IVIG ميبي، بلازما فارسز ميبي. العيانين دول بيحتاجوا سبورتيف ميجرز للستيزرز، للديهايدريشن، كانتي فايرال. هعرض حالتين 3 من الحالات اللي احنا بنقابلها. في دي 4 سنين، بنت عندها 4 سنين جايه بسكيميك ستروك وجايه برايت سايدد هيمي باريسيس وفيشال بولسي. هنا مش عارفه، انا مش ليجن واضح هنا، هو اسكيميك ليجن موجود في البيزال جانجليا، وفي هنا انهانسمنت في الميدل سيريبرال ارتري. ولما عملت MRA واضح هنا في الديفكت اللي موجود في الميدل سيريبرال ارتري. البنت دي عملت بايوبسي وطلعت ليمفوسيتك فاسكولايتس نون بروجريسيف. الحالة الثانية دي بنت عندها 8 سنين جاية بليفت سايدد ويكنس وبروجريسيف. البنت دي كانت واخدة اميونايزيشن للكوفيد، وبعد ما خدت الاميونايزيشن بحوالي 8 أسابيع حصل لها كوفيد انفكشن بروفد بالبي سي ار، وبعدها بعد ما خدت الانفكشن ب3 أسابيع ظهر عندها الاسكيميك ليجن اللي باينه في الاول هنا، اول شريحه، وبعدين فضلت بروجريسيف دي بعد حوالي 3 أسابيع. الشريحه السلايد الثانيه بعد 3 أسابيع حصل اكسبانشن وليس انهانسمنت في السنتر. اخر واحده دي بعد 10 أسابيع من الانفكشن البيشنت دي باست اواي. 10 أسابيع في خدت الناحيه الليفت كلها الرايت هيمسفير وعدت بالكوربس كالوزم على الناحيه الثانيه. الحاله دي اتشخصت بوست مورتم بايوبسي بالبايوبسي ليمفوسيتك فاسكولايتس. الحالة الثانية دي adolescent عندها 14 سنة جاية برايت سايدد هيميباريسز واخدة هنا التمبورال لوب في سكيميك ليجن في السلايد الأولانية هنا، وواضح معاها إنه واخد الانترنال كاروتيد والميدل سيريبرال ارتري على الناحية اليمين. الحالة الثانية دي 4 سنين فيميل برضو جاية بديفيوز ليجن في الام ار اي، مفيش سكيميك ليجن واضحة، ودي البايوبسي بتاعتها جاية بكونفيوجن، والثانية ليمفوسيتك انفلتريشن بيري فاسكولار. دي another case reported COVID. دي فيميل عندها 26 سنة جاية بليفت بيراميدال تراكت ليجن ليفت سايدد ويكنس وهيمي باريسز. الليجن برضو باينة في السلايد الأولانية اللي هي ايه، واخدة البارايتال والفرونتال لوب، وبعد كده الاتجاه من أول الاي لغاية الاي ده سيريال باي تايم. الحالة دي اتشخصت بالبايوبسي وان هي ليمفوسيتك فاسكولايتس من الاي للجي دي بعد 6 شهور من الاستيرويد ثيرابي. اعتقد انه واضح الريزوليوشن بتاع الفاسكولايتس، ودي كانت البايوبسي بتاعتها، ودي كانت كوفيد تريجرد. الحالة الثانية ده 62 مان جاي بابنورمال بيهيفير كونفيوجن وهيدك، وعنده عند الوايت اروز من هنا في اسكيميك ليجنز سب كورتيكال، ولما اتعمل له بوست جادولينيوم الشكل الاخير اللي عليه الارو هيد ده كان ليبتومينينجيال انهانسمنت، وده مع السمول فيسل فاسكولايتس. الام ار اي بتاعه كان نورمال، والبايوبسي بتاعته كانت ليمفوسيتك فاسكولايتس. فالسي ان اس فاسكولايتس should be suspected في حالات اللي فيها cerebral ischemic episodes اللي عندهم different vascular beds، العيان اليونج ايج اللي ما عندوش traditional cerebral risk factors، اللي عندهم chronic meningitis مفيش infection مفيش أي other malignancy، معاهم chronic headache ما بيرتاحش، cognitive disorder confusion من غير aseptic meningitis، unexplained focal أو diffuse neurological dysfunction. التشخيص بتاعها مش one man show، محتاج نتكلم مع الراديولوجيست مع النيورولوجيست to confirm the diagnosis، أحيانا مع الهيستوباثولوجيست. and thank you.
Thank you very much for this wonderful presentation and the cases. Oh yes, we have one question.
الحمد لله عرفت أسأل. بعد المحاولة الرابعة يعني الحمد لله. طيب شكرا يا دكتور دينا، طبعا برزنتيشن كالعادة يعني مغطية كل حاجة، بس هو الموضوع فعلا صعب. أنا هقول يعني كلاسيك حاجة إحنا كلنا بنشوفها تقريبا كتير قوي، الحالات اللي حضرتك وضحتيها والبرزنتيشن كله كان على حاجات واضحة وما فيهاش كلام. السيناريو اللي بيجي بيبقى كتير قوي، بيبقى حد ميدل ايج وبيبقى عنده حتى نيورولوجيكال
يعني هي الحاله اللي عرضتها ليلى في الاول دي كانت ماشيه، احنا كنا ماشيين في سكه ان الحاله سي ان اس فاسكولايتس وات ايفر هتطلع هي ايه، احنا ما كناش عارفين
بالظبط.
بس دي كانت يعني ابلكيشن اللي انا كنت بقوله دلوقتي.
تمام. بيبقى الحالات بالذات الهيدك، لان الهيدك حاجه جنرال يعني ما هوش الفوكال نيورولوجيكال ديفيسيت واضح. حضرتك بيبقى عنده هيدك يروح يعمل MRI يلاقي ليجنز بقى غريبه اللي احنا كلنا بنشوفها، الهايبر انتنس وايت ماتر ليجنز الصغيره مش موجوده في الجراي ماتر، موجوده في الوايت ماتر وعددهم صغير ومش واخدين الديستريبيوشن بتاع الMS وبتوع النيورولوجي يقولوا ده مش دي مالينيتك مش منظره. نعمل MRI والMRI كده، الMRA فري، الMRV فري، نتكلم في بايوبسي لا ده ليجنز قد كده في الوايت ماتر وصغيره، ناخد CSF يطلع البروتين عليه حاجه بسيطه. السيناريو ده اتكرر مثلا معايا في 20 عيان. حضرتك رايك ايه في حاجه في السيناريو زي كده؟ بيبقوا مصرين بقى يدوا ستيرويد.
هعمل فولو اب للعيان ده وهعمل له كوركشن لكل الهايبرتنشن ممكن يديك شكل.
لا ما ده بعد اكسكلودنج كل
يعني
السيستم.
تصلح كوركت اي ريسك فاكتور في العيان ده وهتعمل له فولو اب. اذا ما كانش عنده اذروايز لا كلينيكال. وحاجه تانية التايم اوف لايت MRA اللي هو بيرسم لك الارتري ان تايم، يعني بيوريك الفلو بتاع البلاد فيسل. فاذا العيان ده عنده ستينوزس بيبان. فالتايم اوف لايت اعتقد واحده من الموداليتيز اللي انت ولو حد من الراديولوجيست موجود ممكن يصحح لي الكلام اللي انا بقوله. يعني بيبين السمولست ديفكت او الستينوزس ان تايم وانت شايفه، ما بيعتمدش بقى ان الحاله اولد. انا شايفه زي ما بنعمل دوبلكس كده، هو بيعمل تايم اوف لايت MRA. فاذا كان ده ممكن يفيد جو اون بروسيد.
لكن حضرتك مش هتعالجي حاجه زي كده طبعا
انا بالنسبه لي
بالمنظر
هعمل له فولو
بالداتا
اب.
دي.
هعمل له فولو اب.
Okay, thank you very much.